Good morning. Thank you for this opportunity to speak to the panel. My name is Steve Xenakis. I'm a psychiatrist, former Army Brigadier General, Medical Corps officer, served on active duty for 28 years. I have a part-time clinical practice and consult with the Department of Defense and other government agencies on neuropsychiatric conditions. Some gaps in our clinical care and research for us to recognize. Medications do not help a significant fraction of our patients. About 25% of patients do not respond to SSRIs. Less than a third of depressed patients achieve remission within 8 weeks. There's a high non-compliance amongst drug and alcohol abusers, and medications are probably overprescribed for sleep and pain disorders. CES is safe, practical, necessary, and effective. Regarding safety, these devices have been used for more than 3 decades, as you've heard. There's no record of significant or dangerous adverse events, including seizures. There are no serious side effects caused by CES, and the incidence of minor side effects, such as headache and skin irritation, is low, and the effects are transient. As noted, no treatments for PTSD or mild concussion are identified by the Institute of Medicine as substantially effective for soldiers and veterans. There is no gold standard, in fact, when we come to our clinical practice. We have heard today that the scientific data, while not perfect, does show significant evidence of effectiveness. We've had top-tier academic psychiatrists prescribe the devices. They are widely used because they are effective and have been for decades. The research shows that there is a biological effectiveness in the increased levels of CSF serotonin and beta endorphin, as well as plasma levels of neurochemicals. CES is a practical treatment, as the patient can use the device in the privacy of the home setting, and you've heard in the combat arena and the theater downrange. It does not require frequent or intense visits to a practitioner's office. CES is not costly as compared to other treatments, either ECT, TMS, many medications, or alternative treatments including interpersonal therapies. I prescribe CES for these co-occurring symptoms to patients with mood and anxiety disorders, including PTSD, sleep disorders, comorbid chronic pain, and alcohol and substance abuse. And I've attempted today to illustrate to you that I believe that the overwhelming responsibility that we have to the welfare and quality of life of our patients far exceeds what is the confidence that we have in our scientific method. And I say that as a clinician who has soldiers and veterans and other patients come to me suffering with the problems of anxiety, depression, insomnia. And I say it as a general who sat and advised the most senior leaders in the Department of Defense and looked out to what would be the consequences of 10 years of war. And having served during the Vietnam War and watched my colleagues and fellow soldiers who then went out for years and suffered with their PTSD that took our profession a while to establish and validate as a diagnosis. It took our profession a while to recognize the effects of Agent Orange. When we have groups of patients, less than 50%, who are satisfied with the treatments that we are providing, do we not have a responsibility to take a reasonable risk when we acknowledge as a group that the risk for a particular treatment is infinitesimal?